So we're going to talk about drugs which have been approved for the treatment of cardiac disease in Europe. And this would include loop diuretics such as furosemide, inotropic agents such as digoxin and pimobendan, RAS suppressants such as ACE inhibitors including benazepril, enalapril, ramipril, and imidazopyr, and aldosterone blockers such as spironolactone. While beta blockers may indeed have a use, none have been approved for use in animals in either the United States or in Europe. Lastly, vasodilators, including the ACE inhibitors that I've already mentioned, which are mixed vasodilators, and the inodilator pimobendan can prove useful. So let's explore the mechanisms of action of these drugs. Loop diuretics are our most important and most often used diuretic agents. The prototype of this group is furosemide, and you can see from this chart that it works on the ascending loop of Henle. It does so by poisoning a sodium and chloride cotransporter such that sodium is maintained within the lumen of the nephron, drawing water with it to produce a profound diuretic effect. The renin-angiotensin-aldosterone system is very important in the pathogenesis of congestive heart failure, and I'd like to explore that briefly with you. This system is quite harmful in patients which have a fallen cardiac output with chronic RAS activation. The specific factors that activate the RAS system are a fall in blood pressure, reduction in renal blood flow, activation of the sympathetic nervous system, and a fall in sodium intake. Most important to this discussion is that a fall in cardiac output or the heart failure state all work to cause renin to be released from the kidney. This converts angiotensinogen to angiotensin 1, and then with angiotensin converting enzyme, angiotensin 1 is converted to angiotensin 2. This stimulates the adrenal gland to reduce aldosterone, which is oftentimes helpful on the short term, but very harmful when chronically activated. What aldosterone does is causes baroreceptor dysfunction, as I've already mentioned, pathological remodeling of the heart, the kidneys, and the blood vessels, and also causes salt and fluid retention with potassium wasting, which then produce signs of congestion, and hypokalemia leads to arrhythmias and muscular weakness. In addition to that, angiotensin 2, which turns on aldosterone, is a potent hormone in its own right. Angiotensin 2 causes pathological remodeling of the heart with apoptotic cell death, replacement with fibrous tissue, and also causes potent vasoconstriction, clearly a problem in people or animals who have a fall in cardiac output. We can block this then using angiotensin converting enzyme inhibitors or ACE inhibitors, as you see here, blocking the effects of ACE and thereby reducing the production of angiotensin 2 and aldosterone. Second to that, aldosterone receptor blockers may work specifically on the organs which are damaged by aldosterone. As I mentioned, the kidney, the heart, and the blood vessels. Aldosterone receptor blockers such as spironolactone have in recent years become heavily used in the management of heart failure because of this benefit. Aldosterone receptor blockers include spironolactone and eplerenone. One has been recently approved for use in Europe, and that's called spironolactone, trade name being Prilactone. These are mineralocorticoid receptor blockers or aldosterone receptor blockers, and as is mentioned earlier, these receptors are located in the heart, blood vessels, and kidney. By taking the place of aldosterone on these receptors, aldosterone receptor binders prevent the harmful effects of remodeling. They reduce fluid retention, and they minimize baroreceptor dysfunction. The next group of drugs I'd like to talk with you about are the inotropic agents, and the newest of those and most potent of those is pimobendan. And this drug works in a unique fashion in that instead of increasing the amount of intracellular calcium to attain its goal of improving contractility, it actually increases the sensitivity of the calcium that's already in the cell to the troponin molecule. And what happens is when calcium binds to this troponin molecule, it alters the structures such that it allows for interaction of the actin and myosin cross bridges. And this then allows shortening of the actin and myosin molecules, producing contraction. The more calcium that's present, either by increased calcium levels or by increased sensitivity to calcium, enhances that effect. So increasing the sensitivity to calcium then results in increased contractility, but because it doesn't increase the amount of calcium within the cell, it has less arrhythmogenic potential and also does not cause a dramatic increase in the myocardial oxygen needs, which are both beneficial. Pimobendan is also a vasodilator, and we'll talk about that more subsequently. The phosphodiesterase inhibiting portion of this drug produces mixed vasodilation, meaning that it causes arteriolar and venous dilation. It's shown to have beneficial effects in diastolic function, as well as being a potent positive inotropic agent improving systolic function. Different than most inotropic agents, it actually reduces myocardial oxygen consumption and has the added benefit of decreasing levels of cytokines such as tumor necrosis factor alpha, which have been implicated in worsening the signs of heart failure. The next positive inotrope I'd like to discuss with you is digoxin. Digoxin is a derivative of the foxglove plant, and although it has been approved for use in dogs in Europe, there are no studies which demonstrate proof of efficacy in this species. This drug works differently than pimobendan in that it inhibits the sodium-potassium ATPase pump in cardiac myocytes. In doing so then, it increases intracellular sodium to exchange with calcium, thereby giving a positive inotropic effect via increased intracellular calcium. It turns out that this is a weak effect as compared to newer positive inotropes. An additional benefit that comes with digoxin is that it normalizes the baroreceptors. In heart failure, as we've already mentioned, baroreceptor function is decreased. Digoxin resensitizes these baroreceptors to arterial blood pressure, and then increased vagal tone is accompanied by a reduction in sympathetic output, thereby slowing heart rate, which is a desirable feature in the management of heart failure. I should point out to you that we now have another way to normalize baroreceptor function, and that's by blunting the RAS system, because this abnormality occurs when aldosterone affects the baroreceptors. So we can block this with digoxin, but also with ACE inhibitors and spironolactone. The drawbacks to digoxin are that it's arrhythmogenic because it increases intracellular calcium. Also, it has a narrow therapeutic window, with the therapeutic benefit being followed closely by toxic side effects as the dosage is increased. This drug has fallen out of use by and large, with the exception of utility in dogs who have atrial fibrillation and cardiac disease, because it slows conduction through the AV node. Secondly, digoxin may be utilized when finances preclude the use of the stronger inotrope pimobendan.